Good evening. I think we will go ahead and get started. This is a nice turnout tonight. I appreciate everyone coming. My name is Sally Ross Nolan. I'm the Communications Director at the Clinical Neuroscience Research Unit and Brain Imaging Center. We are part of the Department of Psychiatry at the University of Vermont's College of Medicine. I would really like to thank our sponsors for this year. This program would not happen were it not for their generous support. So I'd like to thank Armistead Caregiver Services, the Converse Home, Home Instead Senior Care, and Shelburne Bay Living Center. And I'd really like to thank them a lot. So tonight we're really happy to have Dr. Naylor with us to talk about chronic pain. Dr. Magdalena Naylor is a professor of psychiatry at the University of Vermont College of Medicine, director of the Mind-Body Medicine Clinic, and associate director of my department, the Clinical Neuroscience Research Unit, and again, part of the Department of Psychiatry. Dr. Naylor received her MD and PhD from the Warsaw Medical University in Poland, and her training in psychiatry at Duke University Medical Center. As a clinician, she specializes in the treatment of mood and anxiety disorders and other chronic conditions such as obesity and pain. She utilizes behavioral and cognitive techniques in both individual and group therapy. Dr. Naylor's research is focused on neuroendocrinology of mood disorders, with a special emphasis on depression and cognition in menopausal women. She has also focused attention on the development of novel modes of treatment for chronic pain, obesity, and alcohol dependence. She created and pilot tested an automatic telephone intervention called the TVIR, which stands for Therapeutic Interactive Voice Response, for the treatment of weight control, chronic pain, and alcohol relapse prevention. Her recent interest is to study effects of coping in chronic pain utilizing fMRI, functional magnetic resonance imaging, as it examines the neural basis of chronic pain in adults. Dr. Naylor is dedicated to exploring how the differences in the brain's functional and structural connectivity may underlie pathophysiology of chronic pain and the mechanisms of treatment using neuroimaging and genetic techniques. Dr. Naylor is a recipient of multiple NIH grants for her work on chronic pain, both for testing the effectiveness of cognitive therapy and neuroimaging studies, which include both small pilot studies and large-scale randomized control research studies. Her most recent award is a 2-year study looking at brain changes in adult patients with chronic back pain before and after cognitive behavioral therapy. We have passed out articles from 7 Days about Dr. Naylor. There's information at the back on contacting them. Also, most of you should have brochures. There's also other information from both of the sponsors and from my specific department out on the tables. So please help me welcome Dr. Naylor.
Thank you, Sally, for this introduction. As she mentioned already that I am from Poland, so I have an accent, and I hope you understand me well. We'll be talking today about chronic pain and how to live better with chronic pain. And as I mentioned, Sally mentioned, I am recently interested in the neuroplasticity of the brain in response to cognitive behavioral therapy and also in response to pain. So I will try to convey to you in hopefully easy way that's very difficult technique of doing neuroimaging and how this can influence our pain can influence our function of our brain. Any questions, if something is really very difficult to understand, if you can answer the question while I speak. So my talk outline, I will try to answer 3 questions. Is the central nervous system processing altered in chronic pain? So it means if pain chronic pain is a response to altered change brain functioning, or if the brain is also changed, the function of the brain because of the pain. There is a kind of dual work. And what are the new and better ways of coping with chronic pain other than taking medication or surgical procedures, interventions such as interventions which are mechanical interventions. I am interested more in, are there ways that we ourselves can influence the pain, our internal way of coping with pain? And then if there are better ways of coping with pain, can we reverse that altered central nervous system back to normal? Can we change it back, and is our brain plastic enough that we can change back to normal? So at first I would like to talk about brain imaging, how we can test pain through the brain imaging. And I don't want to go into what is functional MRI or PET scans, but probably some of you who have chronic pain, they had, you had some imaging or low back pain, or some of your loved ones, and you know that we can check the structure of the body through functional MRI. However, the newest technique is also that we can check the function of the brain, that when we stimulate the brain through different pictures, we can see how, for example, the brain responds. And that's what is functional MRI, functional magnetic resonance response. But at first, I would like to see and to convey to you, can we see actually the pain in our brain? Because, very often doctors say that pain is just in your head, What I actually agree, most of our pain is in our head because it goes to our central nervous system. It's processed by our central nervous system. So what we do, and for many years, other people before us did it in different centers, like here. I will be telling you about some of the studies done by Dr. Catherine Bushnell and David Semyonovich from McGill University. We collaborate with them. They are our consultants and collaborators. And what they did is that then when they apply the painful stimuli, and painful stimuli, what we apply is by touching your body with, that on the right you could see the there is this thermode here, and when we apply this thermode, we can change the temperature of the thermode to high temperatures or low, below 0 Celsius. And then, at first, as warm temperature, oh, it's nice and pleasant, but when we increase the temperature up, after there is a moment that you feel that it's not pleasant anymore, it is painful. And this could be what we call pain threshold. Then when we go higher and higher, then we ask our patients to tell us when they cannot stand it anymore, that this is it, and this is a pain tolerance. They cannot tolerate any higher temperature. So that's what we test, and this is a very important part because patients with chronic pain very often have a different pain threshold. They feel pain in lower temperatures than other people. So patients with, for example, low back pain, like this gentleman in this picture, it's very difficult to test, put somebody in the scanner and, it's very difficult. There are some techniques. Finally, we start looking at what is, basic, some functional MRI can show that actually chronic pain, but it's actually difficult to see the pain in the brain. But we can see the pain when we apply acute pain. So what it is that by now we know that there is what we call a pain matrix. It means in the brain, there are parts of the brain which when we apply, when you feel pain, acute pain, then there are certain parts of the brain which lighten up. Like here, we call it, S1, which is somatosensory cortex, S2, and then this is insular cortex, and what we call also anterior cingulate cortex. Also, there are other parts of the limbic system. A limbic system is a part of our brain that responds to fear and anxiety or anger. We are anxious. We are, like anxiety. Going to the dentist. Most people don't like to go to the dentist because it hurts. by, you know that you have to have done, root canal, you have some anticipatory anxiety, how it's gonna be, are they going to numb me well enough, and so on. This is, what we call amygdala, that's part of that brain, and that's also this part of the brain, it responds to the painful stimuli. So that's what we have. It says what they call pain matrix. So we actually, scientists right now, by now, we know where to look in the brain to see which part of the brain would be responding to painful stimuli. And the pain network activated is by any kinds of type of the pain. So it could be, arthritis. It's almost like some of you who have arthritis, it almost feels like there is some warmth there, it's, and that painful stimuli. Could be, when we are choking on something, or have a heart attack, or when we have a low back pain, or when our body, integrity of our body is changed. All of that that information goes to the brain, and that pain matrix I was telling you about will be visible in the functional MRI. But there are also another part of that, except for brain matrix, pain matrix, I also told you about, that insula, ACC, or the amygdala is, stimulated by painful stimuli. We also know that there is a pain, it's a somatosensory, which is a sensory sensation, which we feel pain, but also if, for example, if the pain is too high or too long, when we call it, it's an experience of suffering. So pain, it has a dual, there is two parts of the pain. The physical sensation and the emotional sensation. If we suffer, those of you who have chronic pain, you know that it's also a suffering. It's very rarely that we can say, and that's what we try to teach you, to decrease your suffering. Yes, your pain might be high, but how you respond to the pain, how you understand the pain, what's the meaning of your pain, how much anxiety you have, that's the part of the suffering. And we will try to separate those two things and show you that emotions influence pain. But, for example, there are parts of there are different pain syndrome which have, all of that in addition to regular suffering, like, going and having drilled your canal in your tooth canal, that there is suffering. But it will be over. This way or the other, half an hour, 2 days, 3 days will be over. Some of you who have chronic pain, and some of my patients who have chronic pain, most of my patients have chronic pain for about 10 years on average. Some of it for 20 or 30 and 40 years. So, living with pain every day, it's a lot of suffering, isn't it? When you have a low back pain, or specifically fibromyalgia, irritable bowel syndrome, or, rarely, but there is what we call vulvovestibulitis. It's a part of our women's genitals which respond to regular touch with the feeling of pain. That has a lot of, part what we call, psychological component. And it is true that physiological factors influence pain perception. I always tell my patients an example of, majority of you here in this room had children or watched children play. And I always remembered, my son, who was like about 2 or 3 years old. I'm coming back from work, and he's playing in some front yard, and he saw me, and he starts running to me, tripped over, fell down, hit the head against something, and I'm thinking, oh, this is gonna be tragedy right now. He's gonna be crying. No, he picked himself up and goes on, and mommy, nothing. Because he was so happy to see me that, what we call the gating mechanism in our spinal cord was closed. Our emotions, his positive emotion to see me, he didn't feel pain. For 2 years old, he didn't say, oh, I better don't cry because mama would not like it. It's this way children don't think. It was just, that emotion, positive emotion, did not allow that painful sensation, physical sensation to go to the brain. You know, some of you probably have an experience, you have guests at home, you are cooking, you are preparing your salad, everybody is in your kitchen, of course, everybody wants to be with you, you are chopping your vegetables, and where is this blood coming from? You didn't even notice that you hurt your finger because you were so distracted by your company, by having the guests and all that, you didn't even notice that. So those are, you know, of course, very simple examples of how emotions, positive emotions, can influence the pain. So, but also, this is true when the pain is acute or chronic, okay? This is not just applying to acute pain. So what we try to teach our patients through different coping skills, you know, to be with your pain like, you know, being the party all the time, okay? I'm not going to feel this pain, or my mother is coming back from work, or it's difficult to say that, but, you know, to change the meaning of the pain and into such that it will be maybe hurting less, or if it does not hurt less, you will suffer less. So psychological influences, that experience of the pleasure or emotions, negative or positive emotions, also has representation in the brain, okay? So there are what we call a neural substrates. And the very first experiment, very simple experiment you can do is that you can, that what Dr. Bushnell from McGill University did, is that she was, as you could see, this fakir here lying down on those nails and reading a book, and okay, it's a distraction. So our attention modulates the pain perception. And what she did is, and her team, is that she was applying those painful stimuli to patient's hand or leg, and then asked the patients to pay attention to that pain, so attend to that pain. Okay, so you could see here that, you know, S1, you know, this is this, you know, somatosensory cortex is firing up, you know, even to red. It's blue and green and yellow and red. It's a lot of pain. The same painful stimulation applied when those patients were applying some distraction techniques. Thinking about something pleasant, you know, or singing in your head, something which you like. You distract yourself from the pain. As you could see, this is significantly less, you can see, because in functional MRI, the less stimulation is more blue, red is more stimulation. So it's a very simple experiment, and that, you know, if we put in the scanner my son, that's what would happen to him. So emotional states appear also alter the pain. As you know, there are people who, you know, in the past or right now, we know the stories that religious beliefs actually caused that people did not feel the pain. They were taking painful experiences with a smile on their face. And they were not pretending. They really did not feel the pain. The same is when you go, you know, to the dentist, as I was talking to you about, you know, if you are very apprehensive, and right now actually I'm reviewing one of the papers to one of the journals showing actually the dental pain, and there were, you know, checking how this expectation of pain, people who are very anxious and those who are calmer, how their brain responds to that, you know, to that. And when you go to the dentist and you are very anxious, oh my God, it's going to never be, you know, they are going to, you know, they actually will not numb me, and you are very anxious, and what we call, you know, you catastrophize, then you can have more pain. If you are thinking about something pleasant, like for this gentleman, then you can actually, you know, go through the drilling and without even noticing. Here it is also, you know, though this is the anticipation or attention to the pain, actually mood also changes the pain. So pain and the mood, as you could see here, not as bad as the other one, but it still is yellow and green. Then when there is a good mood, Dr. Villemeur and Dr. Bushnell from the McGill University, you know, demonstrated that actually good mood decreases the the pain experience. And this was done again on healthy volunteers. But despite the similarities with acute pain, the chronic pain has a unique impact on the brain. And this is, painting by Frida Kahlo, who is a Mexican painter, and she actually suffered from chronic pain. She had a car accident, actually bus accident, when she was a teenager going to school or coming back from school, I don't remember, and she suffered from chronic pain all her life. And that is how she depicted her pain, being in that cage and her, a metal rod along her spine. And so chronic pain is a little bit, if you live with it every day, it's a little bit different. And we can, there are different types of pain. There is what we call neuropathic pain. It's the changes and disease in the nerves itself or the spinal cord itself. So, for example, postherpetic neuralgia, especially in older people, when the immune system is a little bit less functioning well, the herpes, along your chest or face, and it's really very painful. And sometimes it's already gone, you don't see anything on the skin, and just goes on for months, and this is what we call postherpetic neuralgia. It's a neuropathic pain. It could be also the neuropathic back pain. Most of our back pains is related to what we call musculoskeletal pain, which is muscles or bones. But if it is, damage to the spine or the nerves, then we call it neuropathic pain. It actually has a little bit different perception. And diabetic neuropathy, some of you might have diabetes or diabetic neuropathy. The high blood level of glucose causes damage to the nervous system and may cause pain. So that hypersensitivity to painful stimuli with this neuropathic pain is seen here, also through brain imaging. As you could see here, there is more pain in the right foot and no pain in the left. And you can see here, I don't know if you can notice, but this is right foot, which is affected. This is S1, S2 again, insula, in anterior insula, which front and back of insula, and anterior cingulate cortex. And then this is left, which is non-affected foot. As you could see, there is a difference, how this part is here affected, and here is only just a little bit of blue. Here we have more, and anterior insula, this is nothing. So as you could see, even in the same part of the body, different parts of the right leg, left leg, your pain is represented in the brain in a different manner. So chronic low back pain, it's like we know that, I suffer from chronic back pain, so I know what it is, and it's, also changes, it is part of the musculoskeletal, low back, far away from your brain, but influences that pain processing. And again, I don't want to go, it's a very complex picture, but here at the end, those are the similarities and differences. As you could see, when we have patients and controls, those who don't have a low back pain, no pain whatsoever, and patients who have low back pain, as you could see, there are differences here in the function of the brain. So in 2000 it was documented that we can see the pain in the brain. So as I mentioned, that there are what we called, in the past we were calling them like functional pain disorders. Functional means, it's a function of, how you feel. It's all in your head, yes? Fibromyalgia, irritable bowel syndrome, or vulvovestibulitis, I mentioned, and there is, maybe there is some function. The function is that, for example, my patients are telling me that if I am more stressed, I have, external stressors. For example, there is some problems with the family, financial problems, blah, blah, blah. The fibromyalgia pain might be increased. The same with irritable bowel syndrome. We know that it's very much related to the stress, and patients have more diarrhea or constipation and abdominal pain related to stressors. But we also know that there are changes in the brain. And here you can see that, in fibromyalgia syndrome, there is not only just the pain, there is also somatic pain as well. There is also some suffering, yes? Problems with concentration and remembering, there are headaches, there is, menstrual cramping more, there is, after exercise, there is an onset of fatigue and pain and flu-like syndromes and so on and so on. So those are the symptoms of the fibromyalgia, and the diagnosis is made mainly by a criterion, which is the tender points. I think I'm making a lot of noise for TV, but fibromyalgia patients show actually the greater pain to tonic heat stimuli. I told you that when we increase the heat on that tear mode, and here you could see that there is a little bit of the pain intensity. Patients with the same pain, the same heat. This is our healthy controls. Those are patients with fibromyalgia. The same temperature, and first of all, they feel more pain, but also that this response, as the time progresses, this is 21 seconds, they have a different pattern, okay? And also, we talked about pain sensitivity, the threshold of the pain. We can also, fibromyalgia patients showed altered thresholds to this pain. So, for example, those are our healthy controls, the black blocks, and it's almost the same. There is no similarities as warm detection or cold detection. They can say warm or cold, but they actually feel sooner pain. To the temperature is here minus 15, but this is, what is this? Oh, this is 0, okay, and this is 15, but those, something is wrong here. You have to trust me. So the pain, so here at the hot temperature, as you could see, they are responding with pain to the lower temp warmth, and then healthy patients. So their onset of the pain comes sooner. And, they will not bother you with all those, here images, but fibromyalgia patients, so again, how functional it can be, yes? If you, what kind of function is it? If you can see all those differences in the brain for chronic pain, the fibromyalgia is the disease of the brain, not only the body. The rest of the body, brain is part of the body, but not only in those tender points, it's also changes in the brain function. The same is with irritable bowel syndrome. As you could see here, this is activated cortical, the volume, and you could see the IBS patients, irritable bowel syndrome patients, are in red, and the white blocks are controls, healthy controls. And you could see when we stimulate the activation here, because it was irritable bowel syndrome. So actually what they did, they put a little bit of an balloon in that colorectal area in the colon, and they distended it. So patients, subjects who did not have irritable bowel syndrome, that's the area which was just a little bit, responded with the brain activation, and those to the same tactile stimuli, the patients with the irritable bowel syndrome, that's their cortex responded. As you could see, the statistical significance with the controls is a very, high, and it's significant statistically. So again, even in your guts, but the guts respond, the pain influences the brain. And this is also, similar with this response to this, when there is a painful sensation in the vulval area, those are controls, and as you could see, there is significant different stimulation with the pain patients with they have that illness versus controls. But what's interesting is that not only pain, but also other somatosensory parts of our body is response. So some chronic pain patients have altered also sensory processing in other modalities, such as, for example, olfactory perception. So patients with fibromyalgia, not only do they have different parts of the brain, pain in the body, but also they have more sensitivity to smells, and they do not like, might not like many smells that's, as healthy people. Then the chronic back pain was interesting to find that actually they have, the taste is changed. And this is actually okay, I think, because, it's not very healthy food. But what's interesting also that there are changing in our cortex, not only function, but also the thickness of the cortex in patients with chronic pain. So that what we call gray matter, okay? There is a white matter with the connections between different parts of the brain, and then the gray matter is that very important part for us to think, okay? Think and feel and so on. So there are changes in the brain. And also what is interesting that Dr. Abkarian documented with the chronic back pain patients. This is controls, as you could see, the neuropathic low back pain and neuropathic low back pain. And this is gray matter density, okay? So means how thick that, that your gray area is. As you could see, those people with the different parts of the pain and low back pain and others, those who had the neuropathic back pain, which is really very, those people suffer a great deal. They have a less dense gray matter, okay? I think we could see here that what we call prefrontal cortex and also thalamus is affected. So fibromyalgia patients also have reduced brain gray matter. And tension headaches. I mean, doesn't have to be migraine. It could be a tension headache. Some of my patients with a tension headaches tell me that they have a tension headache every day, and occasionally on top of it, they have a migraine twice a week. And they, so they live with pain every day. And also here the gray matter is decreased in the tension headache. So any pain, and we would know also that the longer you have the pain, it's correlated with the length, how many years you had this chronic pain. It influences the thickness of your gray matter. Which is interesting also, that irritable bowel syndrome, as you could see here, that is the parts of the brain also have thinner. The thickness is not as the same as in controls. So even, irritable bowel syndrome, any pain influences not only the function, but also the structure of our brain. But we also know that the changes of gray matter is also changing the mood disorder, such as major depression and also bipolar disorder. Also, we know that in post-traumatic stress disorder patients, that they are what we call the part of the brain hippocampus. In the hippocampus volume is decreased. So as you could see, those are the blue. They are subjects with both abuse, some kind of abuse which caused the post-traumatic stress disorder to develop. Those are patients, the yellow, subjects with abuse but no symptoms of PTSD. Not every abuse causes post-traumatic stress disorder. Yes, there are some people, a lot of people are abused, but they never develop post-traumatic stress disorder. So the fact that somebody is abused doesn't change the volume of this hippocampus, but the fact that you have symptoms like post-traumatic stress disorder affects your volume of your the very important part which is necessary for memory and consolidation and concentration and so on. Here you know that those with pink are subjects with neither abuse nor PTSD. As you could see, this is significant difference between those two. What is interesting, however, is that similar changes in that hippocampus are also with the fibromyalgia patients. So for many years, I found that patients with chronic pain who come for treatment to me, there's a lot of people who are there with chronic pain, they never come to me because they cope well, you know, so they don't need to come to see me. But those who do not cope well, who are very anxious, for example, they suffer a lot, they come to see me for the coping skills training. And I observed that, you know, for a long time, that patients with chronic pain, if they look to me like patients with post-traumatic stress disorder. They are very anxious. You know, for me, pain itself, to live with pain every day, is a traumatic event. It's a trauma by itself because you have this pain and this pain is with you. But not only that, you know, there are other traumas. Because of chronic pain, very often those people, that changes the quality of their life. They cannot enjoy their stuff, what they do, as well as before the pain. They do not communicate as well. They don't sleep well. They cannot ride horses and continue their hobbies. Some of them have to lose jobs. They cannot have as much sex as before. I mean, this all influences, is traumatic and changes your people's life quality. And this is almost like, again, re-traumatization. You know, I'm losing a job, I cannot sleep well, I'm this and that. And it causes that, that I think that influences the brain function. So again, it's because of the changes of the brain, we have more chronic pain, but also chronic pain itself influences the brain and the function of the brain and the structure of the brain. The longer you have the pain, it influences the thickness of the gray matter. So it's very important to know that it works both ways. And also with chronic pain, what we have, there are also changes in the pharmacology of the function of your brain. So in fibromyalgia patients have altered dopamine function. And that's very often with patients with chronic pain, they have depressive symptoms. And we don't know really how those two things work. There are some people who have chronic pain, they never get depressed. Some people, however, because of the pain or other, you know, as we talked about, losses because of the pain, they might develop depression. And we think, you know, this dopamine function contributes to that. And then also, you know, how we, what we call here a mu-opioid binding potential means we have our natural opioids, you know, like morphine-like substances in our brain, in our body. And it doesn't function as well as in patients with people without pain. And also, you know, the emotional and cognitive impact of chronic pain. So again, because we have pain, how does it influence our cognition? You know, again, I'm going back to fibromyalgia because it's kind of interesting that patients with fibromyalgia say, I have fibro-fog, fibromyalgia, you know, fog in my head. I don't concentrate as well. I don't remember as well. And it is not really what we thought, you know, in the past that, oh, because of the pain, you know, because you have high level of pain, so, but if you take away that pain, you know, on the day when you don't have pain, you would concentrate better. It is true to a certain extent that pain itself, when you have a high level of pain, of course you don't concentrate well because you are concentrating on the level of pain, how you have to sit or move. But this is a little bit different. That is that even if you don't have pain, they continue to have, because fibromyalgia is up and down, they feel better, they feel worse, up and down, but the fibrofog continues. And it also, you know, that when they test that fibrofog, what that means, they were doing working memory test and long-term memory and verbal fluency. Those tests were impaired. There were deficits there. And then what's interesting, chronic low back pain, chronic pain, doesn't have to be low back, but chronic back pain. It could be low, it could be in thoracic pain, you know, in your neck. Chronic back pain patients so also reduce what we call ability for emotional learning. I'm not going to go into that, you know, how they were asking them to gamble and play cards, you know, and they didn't learn as well the rules and how to avoid being, to lose the game because, you know, the lower back pain influences your ability also to concentrate and to learn, emotional learning. So in general, conclusions from that part of the lecture is that chronic pain patients have altered pain processing in their brain, loss of brain gray matter, it's thinner, and changes in this neurochemical function, and also cognitive deficits, means the memory, attention, and so on. And those changes appear to be related to duration of pain, and it's very, very important that it's related to duration of pain. So you all, if any of you or people with chronic pain should not, you know, oh, just go with the flow, I'm just suffering, you know, I'm gonna endure that pain. No, you have to treat that pain. And the same is for physicians. Physicians should not, you know, ignore pain. They need to treat it as soon as possible, because the longer you have the pain, the more damage that pain will do to your brain. So what are the new ways? And you know, I'm going to right now tell you what we do. What are the better ways of coping with chronic pain? So yes, you have to use medication, some of you. You can use musculoskeletal, you know, you can use muscle relaxants, you can use sometimes from time to time, or some people need to use on daily basis, opioids. And when patients are coming to see me, you know, if you really feel that narcotics are helpful to you, you know, continue using it. It's not my role to tell you what you should take. But very often, what happens is that narcotic medications, those opioids, contribute further to the GI problems, constipation, the fog, you know, that would be opioid fog or narco fog or whatever we would call it. You know, people don't concentrate well on opioids, memory is impaired, they don't feel happy, they are numb, you know, just go with the flow, there is no enjoyment, no mood swing. So some patients come to us and say, you know, it works for me as far as the pain control, but the side effects, I cannot stand it. Or some patients come and they are on, you know, 120 milligrams or 200 milligrams of OxyContin, and I ask them, what's your pain level from 0 to 10? 8. So why are you using those medications? They give you all those side effects. Oh, that takes the edge of it, you know? So how many times I've heard that? It takes the edge of it. So we try to teach people how to take the edge of it without taking the medication. Or, despite taking medication, you might actually feel maybe decrease the dose, or you use it from time to time, less often. Some patients, they cannot take opioid medications. They simply cannot tolerate it. Or they have a strong belief that they should not. Some doctors don't want to prescribe opioid medications. So there are other methods, you know, like acupuncture, physical therapy, all kinds of stuff, you know, injections of steroids to your back, and so on and so on, radiofrequency ablation. But on top of it, what we can do and what we can teach you is this group behavioral cognitive therapy, which is the teaching subjects to cope better with the pain. And I always say this is not my objective to get you free of pain, because I'm not a magician. I cannot take the pain away. It's really, my objective is to give you skills, so despite that pain, you will be enjoying your life, okay, better. And there are two types of patients, those who finish, you know, because some of them come and they say, oh, this is not for me, I just want to take my medication and give me a break. But those who come and finish this group, there are two types. One type says that I have the same kind of pain, it was 5 before, it continues to be 5, but I enjoy my life better. I can play with my grandchildren. I can go for a walk. I am not afraid of doing something because, I'm not afraid that it's going to hurt me more. Or even if it hurts me more, but I did go for a walk, or I had a great day, at the beach with my children or grandchildren. So the meaning of pain will change. They cope better. But there is also another group who say, actually, I learned to decrease and control my pain. Not only that I control, that I cope better, but I actually am able to manipulate my pain up and down and change the pain intensity. And that's what we actually do in our functional MRI study, that we teach people coping skills. We scan them before, ask them to use all kinds of, the skills that they know on their own in the scanner to control the pain up and down. And then after the group therapy, we ask them to do the same. And we will see how it goes. I would like to see those changes, that they would be less red and less yellow, more blue in response to those different techniques they will be using. And then what we also, as it was mentioned before, I created with my team, it is called telephone-based relapse prevention program, that after the group therapy you can go home and you can use on the phone a special program that gives you pre-recorded coping skills to use. So in group therapy, what we do, we teach them relaxation techniques, we teach people how to change the strategies, cognitive strategies, how to think about pain and stressful situation in a different manner, to change your way of thinking. Because we think that emotions actually is in response to your thought. Very rarely the actual emotion comes before your thought. It's usually, there are some situations that, you look at a beautiful woman or beautiful view, you're not thinking, oh, no, I like it because it is so beautiful. You look at it and it's immediately, the information goes to your core, does not go through your cortex, that gray matter, just goes straight there to that cortex, the visual cortex, and give you this subcortically, that emotion. But this is really rarely, or we can hear some music and go straight to that, auditory, and then, influences that what we call limbic system. So there are some, you hear ta-ta-ta-ta, you're not thinking, oh, this is Beethoven, da-da-da-da-da. You just feel good. That's very fast. But those which go through the road over through the cortex, that's much slower, takes longer time, and usually those are most of the time our thoughts and feelings. And then when we feel badly, if we feel anxious, if we feel angry, it is in response to some thoughts. So we try to teach people how to change your thoughts, to erase all those, bad habits, and create and re-record a good, positive habits. And change your pain beliefs. And with all the patients have their treatment goals, and then we teach them how to monitor pain, but with not too much attention to pain. And also the group therapy is very good in enhancing social support, because very often patients with chronic pain, they feel that they are the only one who suffer that much, and then when they come, say, oh my Lord, there are some people who actually suffer more than I. So, and then the therapeutic interactive voice response is a program which is an extension of group therapy. And all those coping skills which we teach them is also pre-recorded, and how it works, here that patients you would be calling the system, there is a pre-recorded questionnaire, and you answer, that is put in database, and then myself or other therapists is giving you once a month, monthly message. So therapeutic IVR has those 4 components. And then we did studies showing that, here what you could see, that those are patients who were using TIVR and those who were asked, to continue doing what you're supposed to do. They all improved after CBT, after group therapy. But those, stayed the same. They, thank God, McGill pain typical, it's the pain perception. They stayed the same. They did not get worse. most of them on average. But those who were using therapeutic interactive voice response, not only that they didn't relapse, they continued to improve. This was a big surprise for us. The same, you know, what we call total experience. As you can see, this is the statistical difference between those two groups. 8 months later, after the group was over, they continued to improve. And then, you know, catastrophize, you know, they don't catastrophize anymore. Actually, both groups. We did such a great job here in group therapy. We just taught them how to you know, control that catastrophizing, that both groups are improved and then continue. So this was a big success, we felt. And then what was interesting is that, as you could see, this is a group psychotherapy, you know, so people come for 1.5 hours, and we teach them coping skills. They go home, we ask them to practice, we give them, you know, CDs with relaxation techniques, do this, do that, blah, 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 blah. What was interesting is that actually after therapeutic interaction, the physical, this is 11 weeks of group therapy. The physical activity here didn't change during the group therapy, but those people who continue practicing, you don't have to do it with the TIVR. You can practice on your own. But if you really practice all of that, you know, it's just, it shows you that you can continue improving, not only those, oh, less pain and this, but also what physical activity is improved. So group therapy, you're changing your coping skills, you're changing your thinking and your feeling, improves your level of functioning, physical functioning. Cannot be better. I think it's just simply people are not afraid to go out and do things and go for a walk, and instead of asking all the time, could you please help me with that? Say, okay, I can do it myself. So what was actually interesting, that this was not our objective here, but later on we checked, we said, I was kind of skeptical. I was thinking, maybe they are just doing better, because maybe actually that group who was doing the TIVR, maybe coincidentally they actually were using more pain medication, more opioid medication. It could happen. So we actually tested that, and we find out that actually not only that there was no difference between those two groups, actually the group which was using therapeutic interactive voice response was using less opioid medications. People felt better, and they said, oh, I can use less. So now, you know, last part of this talk, I will be talking about how is this actually those. So we are improving those skills, yes? We are improving those patients' function, physical function, cognition, emotion. Is it really reflected in that pain functioning, yes? Brain functioning. So what we did is first, we tried to find out, is there really a difference in our group patients, between controls, which is healthy people, and patients with chronic pain? Is it really a difference in their brain functioning? And we find out that actually this, you know, here we are showing here that amygdala, I was telling you about that limbic system that is, you know, governing that your fear and anxiety and anger. And actually that amygdala is hyperreactive to the fearful stimuli when we're showing those people different pictures during the functional MRI. The people go into the tube, yes, and they are looking at pictures and listen to music, for example, and stuff like that. And this was very similar to patients with post-traumatic stress disorder. So now when we said, okay, there is a difference in brain function, can we change that brain function? So what we did, we scanned, as I said, we scanned people before and after, and we said, you know, is there improvement? And what we find out here, as you could see, as I was telling you before, the more red, yes, like the previous slide, it was very red, and that amygdala hyperactive, and then here it's blue. Okay, so it means what happened that we normalized them. People to the same fearful stimuli respond with less fear. Okay, so this cognitive behavioral therapy was decreasing that fear. The same here, that, you know, what we call the medial frontal gyrus, you know, that part of the brain which is also responsible for your fear and processing, cognitively processing your emotions, it also is decreased. that after the group is less stimulated than before. And here, we talked also, which is very interesting, that so patients were telling us that they have less pain, yes? So what is interesting here, that this is the somatosensory cortex, the activation is less than before. So it is correlated with our clinical data. So the data the patients are telling, I feel less pain, oh, I can see. So our conclusions is that chronic pain patients show greater neural activity in response to emotional fearful stimuli than healthy counterparts that had these red dots there in amygdala. CBT modifies the dysfunctional neural activity, and we conclude that cognitive behavioral therapy, which we teach people, and increase that suppression, that frontal cortex, which you need, you don't need any less, but more actually, so you have to do something to prevent that thinning, so that we think that the frontal cortex suppresses this limbic system, the amygdala, that all those emotions, and decreases the pain experience and reduces the fear. So the final conclusion is group CBT, it's very improves coping skills and improves ability to control and decrease the pain. Interactive voice response as a relapse prevention is a very good technology for patient self-directed treatment, a relapse prevention. And group CBT followed by IVR can be used to not only decrease the pain and improve coping, but also decrease the pain medication use. And the last but not least, that cognitive behavioral therapy modifies, influences, and normalizes this dysfunctional brain activity caused by pain. So those are my collaborators I would like to show you in our department, working Michael Krauthammer, Julie Dumas, who is also a PhD and she will be talking, I think, next week, yes? No, she doesn't. Paul Newhouse, Shelley Nod, and Michelle Comet. And also we collaborate with Duke University and McGill University, as I mentioned. And I really want to thank all our participants, our subjects of our research. This is our group. And I always need to put this on because we are sponsored by the NIH grant, so I put those numbers here, because without the support of NIH, we would not have all these great results. So thank you very much, and I would like to answer your questions. Hopefully you have some. Here. Any questions? Yes, ma'am.
When you talk about the thinning of the gray matter, some of the things I read years ago said we're really only using the small part of our brain to begin with. The part you're talking about is clearly significant for daily functioning, and I know it's statistically significant, but how important is that? In other words, how much more capacity do we have than the amount we might lose with chronic pain?
The question was, that we are not using all our capacity of the gray matter. Yes, we have a lot of cells there in our brain, and we use only part of that. But it depends which part we are using. Yes, so in those important parts, when we lose that part, it might be significant. And if this is, it's not only that they correlate. Oh yes, this is less, this is more, but also the patients have also those cognitive symptoms. So what I am interested, and I would like to see that maybe with cognitive behavioral therapy or any other treatment, I will be doing actually research. I'm planning on doing research to compare cognitive behavioral therapy for chronic pain with some other modality, like treatment what we call on the level or low back pain. For example, they are, it's a modality, you can have a surgical procedure for back pain, or you can have what we call radiofrequency ablation, or you can have some spinal cord stimulator. I cannot use those spinal cord stimulator patients because we cannot put them in the scanner because that would cause some problems. But we would like to compare those modalities and also to see if cognitive behavioral therapy or any improvement of pain will have a long-lasting influence on, for example, white and gray matter. I'm also interested in the white matter because I think that also the pain may damage the rest of our brain, not only gray matter. So we just hope that you can teach other part of the brains how to use it, and so even if you lost it, then you can use other parts of the brain which was not used before and retrain it. So that's actually how it works. Yeah. Yes, sir.
Dr. Naylor, have you studied at all the relationship between family members who live around someone with chronic pain and the education that they receive, and how that would relate to the reduction of pain in the person they're living with?
It's a very good question. I didn't talk about it, but the question is if I or others did any studies on support people. It doesn't have to be always a spouse, but actually the studies were done on spouses, people who lived with patients with chronic pain, and if the education they receive will change also the chronic pain and perception or function of those people with chronic pain. And actually, yes, that Dr. Frank Keefe, which I said from Duke University, he was doing the studies and actually was teaching them those subjects and their spouses. And spouse education has a big influence on the function of people with chronic pain. What we did actually, I am not doing it much because we have only 11 weeks, but in one group session, we invite support people to join us and to share with us their perceptions, tell us if in 7 or 8 weeks if there was any change in patients' functioning, and also we teach them how to communicate better about everyday life, how to ask for help, how to give and take, and they just love it because why I did incorporate it as part of my group therapy, because very often people come in, with spouses to a first evaluation with me, and they say, "So what about me?" The spouse said. "You think it's easy for me? You're treating her, but what about me?" And I said, "Yeah, you're right. You should have those groups for us. Yeah, if you pay me, I will do it." Yeah, no pain, no gain. If we did research, if this is sponsored by NIH, I would do that. Or, if insurance company would pay, this would be a big improvement. And I'm just doing one session, but it really the patients see the difference. Because, there is part, some spouses, let's call it spouses, some spouses are enablers. "Oh, you have too much pain. Oh, sit down, don't do anything." If I sit down and I don't do anything, I will be just sitting here miserable and doing nothing, yes? So, but, some people get into this habitual behavior doing for them. They try to read their mind. They try to read their face, how much pain you have. Okay, today is a lot of pain. Oh, maybe tomorrow will be better. Or some people are opposite, there is very rarely that there is something in the middle. There are some people who just ignore the patients with chronic pain. I have enough. Don't complain. So we try to teach both ways, how to communicate about the pain and your needs. Because if you have chronic pain and you complain all the time, it is like, calling wolf. After a while, nobody answers. Working with couples, it would make a big difference. Did I answer your question?
You did, and I would encourage you to seek some nurses who might be interested in doing that particular research. Being a nurse myself, that's a very interesting idea.
Very good, thank you. Maybe we can talk. Any other questions? Yes, ma'am.
Well, I think you just answered my question when you went to this other ladies, but it was, are there any studies, or are you doing the first one to see if reduction of pain from irritable bowel syndrome or fibromyalgia does result in return of some of the cortical density? And another sort of related question is, have these patients been followed with serial MRIs to see if it just becomes progressively thinner, or?
Yeah, that's another good question, and I say it's a good question because I already asked those questions. We actually applied for an NIH grant to see if, like post-therapy, if we follow people, 8 months later, 12 months later, if we can change improvement, and nobody did it. Nobody did it. So I just hope, I had a okay score, maybe we will get this grant. But it's very important because, 11 weeks of group therapy, to catch the, we are good, but we are not that good. And people are not that good to just learn, new skills, that fast. You really need to incorporate. It needs to be a time in order to incorporate all those skills with everyday life. And then, retrain your brain, and then maybe influence the and have a little bit more growth there. So it needs to be months in order to the function of the brain is much faster. We can change it and we can influence much faster. But that anatomical changes, it takes time. So we will see what comes out. Yes, sir.
The first question is about gray matter density, and I wasn't certain when you were talking about that, how if you had measured the people beforehand and then realized that they had a loss of brain density with gray matter, or they just had it compared to the control group, and so what was how did you get to that decision that there was less gray matter?
How it is measured?
Was it measured beforehand and then afterwards again, or just people who had chronic pain?
Yeah, you're right. It is. I didn't do it. Dr. Abkarian, he just compared. The question is, how was that measured, that gray matter density? And you're right. It could be, for example, this was, a long time ago, the same, chicken or the egg discussion about post-traumatic stress disorder. Maybe people with the less of gray matter get more pain. And it's true that we don't know. And we doubt it, but it's a valid question, that maybe people with less gray matter, they actually get chronic pain. But it was very difficult to find, okay, let's scan, this is $700 or $1,000 per scan. Let's scan a general population and then watch people who got a pain, yes, before they got the pain. It would be, it's very difficult, but it's a very valid point, yeah.
Is there any evidence that people with irritable bowel and fibromyalgia are more likely to become demented as they get older? Since they have less gray matter, presumably?
Yeah, it's another good question. Is there any evidence that people who have that chronic pain, for example, patients with fibromyalgia, that they would become, demented earlier? Though we don't know again, because those are longitudinal studies, and we just started this. The Dr. Bushnell was doing it 2 years ago. A year ago was published that the difference in the gray matter. Then we need to follow those people, and I agree with you. We need to find out not only what predisposes people to develop chronic pain, but also what causes that, the consequences of it in later life. But we know already that treatment of chronic pain needs to be vigorous, and as soon as, not only chronic pain, any pain, first of all, to prevent development of chronic pain, and the second, if you have chronic pain, treat it to do not allow that going on. And people just sometimes say, okay, I just I just endure it, you know. And the suffering is unnecessary. You can really do something about it. Any other questions? Yes, sir.
Is there any difference between men and women who participate in CBT in terms of outcome?
It's another interesting question. I am so interested with that. And you know, there's not too many people who, oh, the question, she's telling me. Repeat the question. The question is, are there differences in the outcomes of CBT between men and women? I am so interested about this because there is not too many men who come for CBT. And I think that there are a lot of men just, you know, they are macho and they say, I just can't endure the pain, I don't need any help. Or a lot of males actually say, I would prefer medication or some treatment like, you know, interventional treatment. And we know that women are more prone to, you know, reflection and self-help, and I think also they like to communicate and meet in a group setting. And so for example, there's a lot of patients before were telling me, guys were telling me, I just can't stand, you know, listening to those complaining women. So I said, okay, I'm gonna do separate groups for guys, yes? And guess what? They were worse complainers. They were complaining. It's like, what? Is my pain bigger than yours? All the time. It's just like, I couldn't believe it. I couldn't. I did the two groups and I said, I am not going to continue. I can't stand those guys. I haven't. So, you know, this was difficult. But the outcomes, you know, so if I have enough guys, I can do the outcomes. So anybody can send me some, you know, males with chronic pain. I would love to see them, and as my subjects for this kind of research, because I don't have enough to analyze the data.
Speak to the cycle of pain and the concept of breaking the cycle of pain.
So the question here is, can I tell a little bit about cycle of pain and how to break the cycle of pain? And in most literature, cycle of pain is considered that there is physical sensation first, and let's say you got some injury to lower back. You know, you lifted something, pain. And then there is a response from muscles, you know, to contract more, and so you have more muscle stiffness there, and then you have maybe changes in your nerves, then you don't feel good, so you start with irritability, you feel stressed, you have more irritability, maybe from irritability it goes to anger and depression if it lasts long. Then you have depression, so you cannot sleep well. Then, you know, you don't sleep well and you have pain. You start walking like that, so your posture is not good. And then, you know, posture is not good, so you have more damage to your back, and, you know, cycle closes. So that is, for example, with the pain, low back pain, but it could be any pain in any part of the body. So what we try to teach our patients and our research subjects, exactly that, so to break that cycle. So I am not telling people that you need to first, you know, work on your relaxation, muscle relaxation, or you need to change your way of thinking and be less depressed, or you need to work on your posture. Different people start in a different level of the cycle, on the side of that cycle, or they might start working on many different points of the cycle at the same time. So what we recommend is that you go, for example, to some, yoga and stretching exercises, so you stretch your muscles. You can go to physical therapy, you can go for massage, but also you can use relaxation techniques by practicing relaxation techniques at home. You also need to take care of your feelings and your thinking and the cognitive restructuring, which we are trying to teach, and being mindful. And then, improve your sleep, blah, 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 improve your posture, so working on all of that. So that's how we understand the pain cycle. So this is the let's say back pain, and then influences your what we documented here, your central nervous system, your nerves, and we try to improve that. There is, right now I'm collaborating also with the other specialist who actually wrote the book, Breakthrough Pain, and his name is, I call him Shinzen, and that's his given name because he's Buddhist monk, Zen monk, but also a specialist on mindfulness, and the last name is Yang. I think it goes Shinzen Yang. And the book is Breakthrough Pain. And we try to, he actually teaches people how to develop that skill in a different manner to break, and actually patients have this breakthrough pain, that there is actually a moment that the pain goes away. I did not achieve that. But there are ways, if you like, there are some ways of contacting him, and he might help you or whoever you have in mind. Yes, ma'am.
Have you done work with people very late in life? Is there any, or is there a sense that there's a sort of cutoff point at which this behavioral therapy wouldn't work? Or is it, in other words, people in their 80s who are having ongoing pain?
Yeah, cognitive behavioral therapy is not it's not good for somebody who's demented, for example. But age, I had patients my oldest patient was 86 years old. I have right now 91 years old, who is actually coming after my group. We find out that she's a yoga teacher, and she comes to my group and does yoga, and she's 91 years old. So age does not prevent anybody to learn those skills, and naturally, if somebody has Alzheimer's or dementia, it's very difficult, but the age is, I had the best experiences with people who are actually, a lot of experience in life, and they know if you practice, you're going to get what you want, yes. Yes, ma'am.
I had read that relaxation techniques are very helpful for muscular pain, but not so helpful for nerve pain. Can you talk about your experience with that?
Mm-hmm. The question was that relaxation techniques might be very good for muscular pain, but not for nerve pain. How I teach about relaxation techniques. A relaxation technique is what I teach is not relaxing your muscles only. This is only one part of that response. What is relaxation techniques? We are teaching people how to achieve what we call a relaxation response. And the relaxation response, it is actually created by, this term was created by Dr. Benson from Harvard, who who documented, and actually he's a cardiologist, and he was doing cardiovascular treatment with patients with high blood pressure at first, and he was teaching them relaxation response. So not really for the your bodily muscle, but muscles of your arteries. Relaxation response is a total response of, counteracting stress response. So muscles are first, but also endocrine system is responding to it, and also sympathetic and parasympathetic nervous system. So your heart rate goes down, your blood pressure goes down, and so on. So it actually relaxation response, if you learn relaxation techniques and you achieve that what we call the relaxation response, would have an effect on entire body. but you're right that it will have a less effect on the peripheral nervous system, which is, you know, the damage to it causes neuropathic pain than musculoskeletal. However, what we try to teach our patients that maybe you will have less pain, maybe you will not have less somatic pain, but you will be responding to your that same pain in a different manner because you will be calmer, you will not be stressed, you will not have that high level of steroids in cortisol in your blood, you will have less what I call sticky platelets, okay? Because in response to stress, you know, when you have, let's say, neuropathic pain or diabetic neuropathy, you know, you are worrying, okay, where is this going? Will I be able to walk next year? Blah, 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 blah. I mean, you can worry. It won't change much. If anything, it will speed up the process, yes? So that's, you know, I don't know if I'm answering your question, but what our relaxation techniques are not just to relax your muscles, but influence entire body. Any last question? Anybody else? This lady had a question before. Okay, nobody else? Okay, you have a right to answer one more.
How long a time would you consider it before you call it chronic pain?
In the literature, chronic pain is 6 months or longer. So for our research, usually we accept patients if it is, you know, around 1 year or longer. But that's what's considered, yeah. Thank you very much to all of you.